We'll move on to the digestive system. And yes, we have scenario number 4 here. Miss Katoria, are you ready to read the scenario for us?
Yes, I can read it.
Thank you, Miss Katoria.
Okay, the answers are A, 43235, B, well, K 21.9, B, 43191, K 21.9, C, 44360, K 21.9, and D, 43200, K 21.9. Extent of examination, upper gastrointestinal endoscopy. Reasons for examination, gastroesophageal reflux disease. Description of procedure, informed consent was obtained with the benefits, risks, including the risk of perforation and alternatives to upper GI endoscopy were explained. The patient agreed to proceed. No contraindications were noted on physical exam. Anesthesia was administered by the ICU staff. See anesthesiologist report. Monitored anesthesia care, MAC, was administered by the anesthesia team. The procedure was performed with the patient in the left lateral decubitus position. The instrument was inserted through the mouth to the second part of the duodenum. The patient tolerated the procedure well. There were no complications. The heart rate was normal. The oxygen saturation and skin color were normal. Upon discharge from the endoscopy area, the patient will be recovered per established procedures and protocols. Findings: the esophagus was examined and no abnormalities were seen. The gastroesophageal junction, upper level of gastric folds, was located 40 centimeters from the incisors. The stomach was examined and no abnormalities were seen. The small bowel was examined and no abnormalities were seen. You have 2.5 minutes to solve.
Okay, coders, so that is time and great answers in the chat. Once again, you all are rocking in the chat. So let me highlight the keywords. We have upper gastrointestinal endoscopy procedure performed. The reason for examination is gastroesophageal reflux disease. A monitored care anesthesia was provided. Left lateral decubitus position, mouth to second part of the duodenum, esophagus was examined, no abnormalities were seen, stomach was examined, no abnormalities were seen, small bowel was examined. Once again, no abnormalities seen. The correct answer, as most of you have said, is going to be option A, curd coding. So we have in our procedure inventory esophagogastroduodenoscopy, and in the diagnosis inventory, we have gastroesophageal reflux disease, and these are all the code options which we have. So 43200 is coding for an esophagoscopy procedure, transoral. So let's cross check with our procedure inventory. Did we had an esophagoscopy performed? No, we had an esophagogastro duodenoscopy performed. So in an esophagoscopy, what happens is the physician will be inserting a scope through the mouth and it will examine, the endoscope will examine all the portion of the esophagus. It won't be examining your stomach or the duodenum. It will just examine the esophagus. And 43200 is coding for esophagoscopy. Well, in our scenario, we can read the documentation where it says that the instrument was inserted through the mouth to the second post part of the duodenum. That means the stomach is also examined, right? Also towards the end, in the findings section also, it has been documented that the stomach had no abnormalities detected, as well as small bowel. So it's not just the esophagus which was examined, it was the stomach also, and the duodenum also. Second part of the till the second part of the duodenum was also examined. So option D is incorrect. Option B is coding for 43191, which is again for an esophagoscopy procedure, and that is also incorrect. So remaining two codes are option A and option C. Option C coding for 44360, which is for a small intestinal endoscopy, enteroscopy beyond the second portion of the duodenum, not including the ileum. Now coming back to the documentation, you can see that the instrument was inserted through the mouth to the second part of the duodenum. So it didn't cross the duodenum. It only reached till the second part of the duodenum. And for 44360 to be correct, there should be the second part of it, the beyond the second part of the duodenum should have been examined, and it should not examine the ileum. So it is incorrect. As per the documentation, we had only examination performed till the second part of the duodenum. That means the remaining option, option A, 43235, is the correct answer, which is coding for esophago, gastro, duodenoscopy, flexible, transoral, diagnostic, including the collection of the specimen, brushing or washing when performed. So it had an so in our procedure we had esophagus examined, we had a stomach examined, and the small bowel, the duodenum, till the second part of the duodenum as well examined. So which means option A is the correct answer. How are you doing, coders? How are you feeling, coders? Did the explanation help? Great, awesome. Okay, good. So let me quickly move on to the next question. Yeah, so this is another image of the esophagogastroduodenoscopy for procedure performed. So as I said, you can see an endoscope will be inserted. It will examine the esophagus, the stomach, until the second part of the duodenum. Okay, great. So let's move on to the next scenario. We have scenario number 5. So let me read out the answers first. We have option A 44227, Z43.2, Z85.0 for 8. Option B 44620, Z43.2, Z85.08 for 8. Option C 44626. Option D 44625. Preoperative diagnosis, history of rectal carcinoma. Postoperative diagnosis is the same. Procedure performed, closure of loop ileostomy with small bowel resection. Enterostomy with intraoperative flexible sigmoidoscopy. Description of the procedure. After induction of adequate general endotracheal anesthesia, patient was carefully positioned in the supine modified lithotomy position for Allen's stirrup. Great care was taken to pad and protect all areas of potential bodily injury. Digital rectal examination revealed a widely patterned circumferentially intact pouch, anal anastomosis within 1 centimeter of the dentate line. Flexible sigmoidoscopy was performed, revealing healthy pink mucosa. The abdomen was prepped and draped in the usual sterile manner, and parastomal incision was made and carried down sharply into the peritoneal cavity. Metacolous hemostasis was obtained with electrocautery. A 360-degree subfacial mobilization was undertaken until approximately 40 centimeters of each the efferent and efferent limb reached above the skin in a tension-free manner. Betadine was insufflated down each limb to verify that no enterotomies or seromyotomies were made. The mesentery was cored and vessels were divided with 10 mm Liga suture impact. The bowel was circumferentially cleared of the fat proximally and distally, and each enter was divided with GIA 100 mm stapling device with blue cartridge. The field was protected with blue towels, and an anti-mesenteric border of each staple line was excised. A side-to-side functional end-to-end anastomosis was fashioned with GIA 100 mm stapling device. The staple line was reinforced for hemostasis with 3-0 PDS2 sutures were necessary, and afferent limb was secured to a efferent limb with a 3-0 PDS2 seromuscular Lambert type sutures. After verification of the meticulous hemostasis, apical enterotomy was secured with GIA 100 mm stapling device. The anastomosis was healthy, pink, and widely patterned, and circumferentially intact, and easily returned to the peritoneal cavity after copious irrigation and verification of meticulous hemostasis. So what CPT and ICD-10 CM codes are reported? Coders, you got 2.5 minutes. Okay, Chorus, I was looking into the chat and looking at your answers. Good coding. Great try as well. Okay, so if you got it wrong, don't worry. You are going to learn something new, and that is always awesome. Okay, so let's review the scenario together. We have a history of rectal carcinoma, closure of loop ileostomy with small bowel resection, enteroenterostomy with intraoperative flexible sigmoidoscopy. That's a procedure performed. We have endotracheal anesthesia given to the patient, supine modified lithotomy position, parastomal incision was made, carried down sharply into the peritoneal cavity, betadine was insufflated down to each limb to verify no enterotomies or seromyotomies. Bowel was circumferentially cleared of fat, proximally and distally, and each end was divided with GIA 100 mm stapling device. A side-to-side functional end-to-end anastomosis was fashioned with GIA 100 mm stapling device. The correct answer is going to be option D. Okay, so first let me let you know what an ileostomy is. Ileostomy is a procedure where in which the lumen of the ileum, part of the small bowel, is brought through the abdominal wall via a surgically created opening called as stoma. So you can see what an ileostomy is. A portion of the small bowel or the ileum is brought into the abdominal wall over here with a surgical opening called as stoma. And in our procedure, we had a closure of the loop ileostomy performed with small bowel resection and an enteroenterostomy as well. So what is an enteroenterostomy? Enteroenterostomy is an anastomosis between the part of small bowel and other part of the small bowel. It can be jejunum or ileum. So what happened in our procedure is that patient was having a ileostomy already over there. So what the physician or what the surgeon perform is he perform a closure of the ileostomy. So in order to close the ileostomy, the physician or the surgeon perform a resection of small bowel as well. So you can see a small portion of the small intestine is also not a bowel, sorry for correction over there. A small portion of the small intestine is resected and the ileostomy is closed. And what he did then next is he performed an anastomosis with the rest of the small intestine with the opposite end of the small intestine as well. So these two portions of the small intestine has been connected with a anastomosis, or what they call an enteroenterostomy. So that's what a procedure performed. Is that clear, coders? Okay, good. So let me move back to the coding portion. And yes, these are all our code options. We have closure of loop ileostomy with small bowel resection and enterostomy as procedure inventory. In diagnosis inventory, we have closure of loop ileostomy and history of rectal carcinoma. So option A, 44227, is coding for a laparoscopic surgical procedure, closure enterostomy. So as I said, it is for a laparoscopic procedure where we had an open procedure performed in the scenario. How do I know that? From the documentation. So it's clearly documented here that the procedure started with a parastomal incision and it was carried down to the peritoneal cavity. So this was performed with a open procedure as an open procedure and not a laparoscopic procedure. That means option A is incorrect. Now for the rest of the option I have done a little bit of churning here. You can see 44620 is coding for closure enterostomy for large or small intestine, and 44625 is for closure enterostomy with large and small intestine with resection and anastomosis other than colorectal, and 44626 is for closure enterostomy, large or small intestine with resection and with anastomosis for colorectal. So let's look at option B, 44620, that is for closure enterostomy, large or small intestine. Why is this option incorrect? Because it is not coding for the small bowel resection, right? We also had a small bowel resection in our procedure inventory and was also documented, right? So 44620 is only coding for a closure of enterostomy of a large or small intestine and not for a small bowel resection. Neither it is coding for an anastomosis procedure. So option B is incorrect, no small bowel resection. And option C, 44626, is incorrect because it's coding for a closure enterostomy. Yes, but there is a resection of small intestine and colorectal anastomosis. So it is for a colorectal anastomosis. We didn't have a colorectal anastomosis. We had an enterostomy. So the anastomosis was between small intestine and not a colorectal anastomosis. So that means option C is also incorrect. And the last remaining option, which is option D, that is coding for 44625, is for closure enterostomy with the resection. Yes, that's mentioning about the resection of the small bowel, small intestine, and anastomosis other than colorectal. So it's for other than colorectal, any other anastomosis other than colorectal. So that suits our procedure inventory as well. And your correct answer is going to be option D. How are you feeling, coders? Are we good? Is explanation good, clear? Shall we move on to the next one? Great. Okay, thank you for being active in the chat and responding, and let me know.
Thanks for tuning in, and until next time, happy coding.